Hello, today we are presenting our project, Investigating the Quality of Urinary and Faecal Continence Management in Residential Care. I will be presenting the first part of this presentation and then we'll hand over to my colleague, Dr. Golenko. In Australia, incontinence is one of the main reasons an individual enters a residential aged care home for permanent care. According to the Continence Foundation of Australia, an estimated 75% of residents living in Australian aged care homes experience urinary incontinence, and up to 50% live with faecal incontinence. The quality of continence care provided in Australian care homes is dependent upon several factors. These include government funding subsidies, staffing levels, level of care requirements of residents, staff continence knowledge and skill, and the attitudes and belief people hold around incontinence. For this project, we were guided by the key performance indicators developed by the Global Forum on Incontinence and explained in the 2018 KPMG Global Strategy Group report. Outlined in the report were the types of persons who experience incontinence, the key performance indicator types, and the overarching domains of clinical, quality of life and economic. This project focused on 4 of the 14 developed KPIs. These 4 KPIs, which were drawn from the clinical and quality domains, informed our research questions. The research questions developed from these KPIs focused on how well nursing staff complete assessments and plan continence care, the strategies staff implement to manage incontinence, staff and resident experience with incontinence, and the impact continence assessment and management has upon resident emotional wellbeing. This was a mixed method study design. The quantitative component was the desktop analysis with an element of qualitative review. This was conducted by myself as a subject matter expert in continence. The qualitative component was interviews with staff and residents at the care home. A comparative analysis of the findings was then undertaken. The desktop analysis of the care home's electronic documentation system found that completion rates for assessment demonstrated a high level of compliance with initial assessment for continence and toileting. However, when it came to review of these residents, only 35% had a review of their continence care plan documented. When this did occur, it was generally attended at the required 3-monthly review timeframe, not if a need arose, such as skin excoriation or leakage beyond the aid. The low percentage of revised care plans could demonstrate a lack of knowledge and understanding of continence and its impact, the skill required to recognise and address changes in an individual's continence needs, or time constraints to attend review. The desktop analysis showed that the majority of residents had very high care needs. These residents had many different health conditions requiring numerous assessments and care plans. While staff identified characteristics known to be associated with incontinence, they generally didn't seem to understand the correlation between these characteristics and resident incontinence. Issues such as skin excoriation, increased falls, withdrawing from socialisation didn't necessarily prompt consideration as to whether the residents' continence needs had changed. It was difficult to garner from the desktop analysis if staff did in fact understand the residents' continence needs, but were just not able to articulate this in their documentation. Deterioration in condition and worsening continence status was noted in excessive or inappropriate pad usage. Identification of incontinence on initial assessment was done well, but documentation did not demonstrate employment of strategies to maintain or improve continence in individual residents. An example is where residents identified as having a history of constipation were only treated with laxatives. No other strategies such as increasing fibre intake, targeted exercise programs, or appropriate toileting position for defecation were documented to assist with constipation management. I'll now hand over to Dr. Golenko. Thank you.
Thanks, Kate. So in terms of the qualitative component, which was the semi-structured interviews, we did interviews with 4 staff members and 5 residents. Unfortunately, the sample size was quite small, which does create some limitations, especially when you look here at the characteristics of the residents. They had relatively low care needs compared to the larger population, which had quite high care needs. Despite the limitations with the sample size, however, when we did the comparative analysis, there was actually quite a high level of congruence between the desktop analysis and the findings from the interviews. So in terms of the first research question, we found that there was a high number of completed assessments, but a low number of assessment reviews. And this is possibly because the assessments are linked with the funding model, whereas the reviews aren't. We also found that there was a low level of resident involvement in care planning. In fact, the residents often didn't know that they were being assessed and that their care plans were being developed. With regards to the second research question, which was around toileting and containment strategies, there was a high level of pad usage, no surprises there, low levels of toileting and other strategies such as diet and exercise. And you can see from the quotes here that both the staff and the residents preferred to use pads and thicker pads. The staff because it saved them time in terms of changing, and residents in case the staff were unable to attend to their needs. So the third research question was around staff experience, and it was quite evidence that there was a lack of training and education in the staff initial qualifications, and also limited opportunities for ongoing education. There was also evidence of heavy workload and burnout, and Fortunately, this was having a negative impact on the inter-staff relationships. So things like lack of trust, blaming were starting to creep in. So the final research question was around resident experience, and an interesting finding here was that residents who had a specific medical cause for the incontinence felt quite comfortable talking about it, whereas those who didn't felt much more ashamed or embarrassed. So this stigma is still a real issue. But we did find that the relationship between the staff and the resident was a really critical factor in maintaining dignity. Residents were really particular around the staff who they felt comfortable with, and staff explained how important it was to get to know the resident to understand their needs. So the key take-home messages from this research are firstly the need for staff education and coaching to build their capacity around incontinence. Secondly, the need for greater resident and family engagement to reduce the stigma. And thirdly, the need to look at the work process mapping and improving inter-staff relationships.